All right, so that should be going live on Facebook here. I'm going to start right at 7 o'clock. I'm going to do my best to get us done in right at an hour. That usually works pretty well. Well, welcome to Pella. Oh, 20 years here in Pella. Okay, you don't need to be welcome to Pella then. Scott, you've been around for a long time. For those of you that are joining us online, I guess welcome to Pella. You can see a little bit of Pella in my background. I don't know where you're from, but today in Iowa, in Pella, it's the low 90s. So it's definitely feeling like summer. My middle child, my son, is a high schooler. He is in the middle of his second baseball practice of the year, so we're glad to have him back out there. I feel like that's a good thing to do, and it's safe to do it right now, but I'm sure it's not feeling like what their typical second day of baseball practice feels like here in Iowa. For those of you that are on Facebook Live that didn't see this before and they didn't sign up to watch it on Zoom, we're going to give these people on Zoom the ability to interact through the chat button feature. But if you're on Facebook Live watching and interested in hearing about plantar fasciitis and foot pain, we're going to talk a little bit about something called Achilles Tendonitis, bunions a little bit as well. The most important stuff we're going to talk about is not just what type of pain you have, but what are, in most cases, the true causes of those problems. And we'll find out tonight that most of what we do to deal with our pains, even with foot pains, are simply things that mask the problem and don't really get to the root of it. So I'm really excited to tell you about this stuff because it is really the only way you're going to get any kind of solution, improvement in your pain that's going to last. So I'm excited to share the information tonight. We're getting a group to show up. I said earlier to Scott when he was the only one on, we have 50 some people, well over 50 I think signed up. So it's a pretty big group. We do these live and in person, these kind of workshops, and generally, if we get people to sign up, about 75% of them come to the live in-person workshop. Doing these online things over the last month, we've found it closer to 25 to 30%. So we'll probably have 15 to 20, maybe 25 if we're doing really well tonight, and maybe catch a few more on Facebook Live. We are counting down to the last few seconds before 7 o'clock hits. If I do that, I'll start the recording, and we'll start in earnest with what we're going to do here today. While I'm waiting for those last few seconds to go, I'm going to give you a view of my screen. So you should be able to see the screen, the slides that I'm going to share with you here tonight. Yeah, just a reminder, it's called The Truth About Plantar Fasciitis and Foot Pain. And I said this to a couple of you that were on a little bit earlier, but we are very interactive with these workshops when we do them in person. But because of COVID-19, we haven't done them in person. We've been doing them online. And so the best way to be as interactive as possible when we do it online through Zoom is this chat button. So just click on that chat button. At any point, if you have questions, I'll keep an eye out for that. It's off my screen now, but a little light shines that tells me that someone has a comment that they're making. So that's great. At the end as well, I'll stick around. Sometimes people have questions they want to have answered at the end. We called most people. If you signed up at least a day in advance, we called you. Got a lot of questions. I know there's a lot of people wondering about plantar fasciitis. We're definitely going to talk about that tonight. But if you have other questions, just hit that chat button. If you're on Facebook Live, you can put it in the comments, and I'll probably get to you later because I can't monitor both at the same time. My name is Troy Vander. I'm a doctor of physical therapy. I have been practicing physical therapy for a long time, almost 24 years now. And it's primarily been in the outpatient physical therapy environment. So that means I work with people that have musculoskeletal issues. The number one condition we see in our clinic is lower back pain. Number two, it's probably tied between shoulder and knee pain, but just behind that is foot pain. And definitely see amongst those that see us for foot pain, a strong majority of people that have plantar fascia issues. So we're going to talk a lot about that tonight. But I want to tell you that what I'm teaching you tonight, 20 years ago, I would have never taught you. As a young physical therapist, I learned a lot, but I've learned a ton more by seeing people, by working with people that have similar conditions, and you see the trends that are developed. And most importantly, I've learned a lot about not just how to, identify what the problem is, but what are the true causes of the problem. We're going to talk about that tonight. I'm with a group called Kinetic Physical Therapy. We've been around since 1998. I'm here in Pella right now. That's where our headquarters is, but we have 7 brick and mortar clinics throughout central and south central Iowa. We got a ton of movement experts, 18 physical therapists, several OTs, assistants for PT and OT, athletic trainers. It's a big group, and we all have kind of different personalities and interests and that kind of thing. But one thing that is true about every one of us is that we're focused on functional assessments and functional treatments. So we have everyone go through what's called 3D MAPS. It's a three-dimensional movement assessment and performance system. And tonight, that sounds like a bunch of hullabaloo, but tonight you're going to learn about why that approach is very important when you have issues of musculoskeletal nature. One of the other things that we love doing is we love helping student physical therapists and occupational therapists. We get a lot of students come through and spend time with us, learning from us. We feel honored to do that because we know that these programs, these educational programs, trust us tremendously. But we like it, again, for selfish reasons too. These students who are soon to be physical therapists and occupational therapists ask a lot of great questions. And so it keeps us on our toes, it keeps our knife sharp, because we need to be ready to give rationalizations for why we're doing what we're doing. We can't settle into habits just because we've always done them. So we really, really love that. And they get a lot out of that experience as well. I want to make sure you get a lot out of this experience too. So let's first talk about who this workshop is for. If you are finding that standing on your feet, walking, those issues are becoming so problematic that you're not doing things that you'd like to do, and therefore you're becoming more dependent upon others, then this is a great place for you to be for the next hour. If you're starting to ask questions like, man, is this ever going to go away, or do I need to have a surgery? Some people even ask questions like, what's this going to do? If I'm not able to walk, what's it going to do to my overall general health? Those are legitimate questions. And hopefully at the end of the workshop today, you'll have some answers to those questions. I think most people come to these workshops because they're having pain with movement. In fact, you'll learn tonight that the complaint, it hurts when I ... That's the second most reason people seek medical help. And so I'm guessing that most, if not all of you tonight, want to be able to move on your feet much more comfortably than you can right now. Another thing we're going to talk about tonight is the fact that both in our lives, as we interact with others, and within our bodies, we are most impacted by the things closest to us. So if you don't feel good, it's hard for you to be in a good mood. And unfortunately, that impacts the people around you in a negative way. We're going to find also that if your heel hurts, if your foot hurts, the thing that's really getting the problem is not necessarily the thing that hurts. It's impacted by the things around it. And if the things around it aren't doing its job particularly well, it's probably the area that you're experiencing pain that is suffering as a result of that. And that is very basically, very fundamentally, the way to determine what the true cause of your problem is and how to fix it to get better. If you're interested in avoiding high-risk procedures or the side effects of medications, and this is a great workshop for you. What do I mean by high-risk procedures? Well, compared to other surgeries on the foot are not as much high risk. It's a smaller body part. It's farther from the heart. But every time you go under anesthesia, there is a risk associated with that. Anytime you open up your skin to the environment, there's a risk associated with that. And if you don't have to expose yourself to those risks, that's a good thing. Ultimately, I hope I'm going to be able to help you understand what it takes to experience pain for emotion. Now, this workshop is for some people, it's also not for some people. And so if you aren't interested in avoiding surgery, or if you're really not that interested in learning about things that you can do, in other words, I'm not going to give you a quick fix tonight. There's no such thing as a quick fix that is also a long-term fix. Quick fixes are usually flashes in the pan, temporary improvement in symptoms at best. And so if you're looking for that quick fix, if you don't want to learn what you need to do and how to implement that, then this probably is not the right workshop for you. If you're more interested in masking your symptoms, or if you have the belief that I know I'm not going to get better unless I'm having a surgery, well, you can save your time and not listen, because we're not going to talk about those things. In fact, many of those things I consider although I understand why they occur, I consider them excuses or something that ignores the root issue. And I want you to avoid it. Okay, now let's be interactive here. I want you to click on that chat button. I want you to answer 3 questions. These 3 questions I ask every client that comes in and sees me as a physical therapist. And so I want to ask these questions because depending upon how you answer these questions, I can tell you whether your condition is something that can be helped, that can be giving you hope. So let's answer these 3 questions on there. What's the activity you've done in the last 2 weeks that contributed most to your foot pain? How high does that pain get on the 1 to 10 scale? Understand, 10, that is the worst pain imaginable. That's, I need to be in the emergency room right now. There's no such thing as an 11 or a 14 or a 25. It's 1 to 10. And then how long have you been experiencing this foot pain issue? I know Scott's been experiencing it for 2 or 3 months, but if you could, all you that are on there, just click on that. Let's hear just a little bit of your stories, and we'll see if these are stories that I can give you some hope about. Oh, come on now. Someone else type in something. I can't get to the chat feature right now, and I think it's because people aren't interacting right now. Help me out. I don't want to talk to myself all day long here, folks. We got 23 participants right now. Surely some of you can give me some information, please. I'm not opposed to begging. Well, okay, no one's going to give me information, so I see how you are. I'll tell you what we hear most of all. Most of all, we're going to hear people that have been experiencing their pain, not just for a few days, but a few months, if not years. Before people get to physical therapists, they've often tried a lot of different things. So sometimes it seems like physical therapists are the last option, the final straw, the last hope. In fact, it's estimated that only 10% of the people that would benefit from physical therapy ever get to a physical therapist. So if you're like that, if you've been having it for quite some time, usually it's a weight-bearing activity that bothers people. Standing, walking, climbing stairs. The first steps of the morning are usually very difficult for people with heel or arch pain. And people aren't usually experiencing 9 or 10 out of a 10 pain. It's usually just that annoying level of pain with these issues. 4s, 5s, 6s, sometimes 7s. Those are the most common things. So if you are like most people, and there's something you can specifically say, when I do that, it hurts. I want you to understand that's actually a good sign. If your pain is reproducible with something, and here are the most common things amongst those that have foot pain issues. You can see almost all of them. I think they all are weight-bearing activities, okay? I want you to know you're in the right place if you actually have something that causes the pain, because we know that if your pain is reproducible, it's also reducible. So we're going to be talking tonight about the difference between a more sinister problem that in most cases does require a more aggressive treatment approach, and something that is mechanical in nature. By mechanical, I mean there is a physical stress that makes it worse, and an elimination of that physical stress makes it feel, relatively speaking, better. So it kind of sounds counterintuitive. So it sounds weird to hear, hey, if something hurts when you do it, that's a good sign. But we know it's a mechanical issue. Let's talk a little bit about 2 types of trauma. I want to contrast acute trauma with cumulative trauma. So let's say some of you may be of an age that you can remember this, or maybe are experiencing this quite well. Remember when you had younger kids and you were walking through their room at night, maybe dealing with an emergency, or maybe they're crying for some reason. You stepped on one of those Legos. That sudden stress that causes immediate pain is called acute trauma. Here's what acute trauma looks like when you graph it. This is tissue damage on the vertical axis, time, and ultimately usually expense on the horizontal axis. This is what it looks like: sudden tissue damage, and then because we're living organisms, as time goes by, we get better. The body makes adaptations to it. That stress that caused it, whatever it was, is no longer there, and the body heals. And in most cases, you'll get below the symptom threshold eventually. So there are lots of ways we can experience this. If you drop something on your foot that's heavy, if you twist your ankle, all those things are acute traumas where it's really easy to understand the cause because the effect is immediately noticeable. The reality is, in my world, though we deal with some of those things, the most common condition we see are those that are developing cumulatively. It's called cumulative trauma syndrome or a cumulative trauma disorder. It looks a lot different when we graph it. Instead of being sudden tissue damage, what you're going to see when I hit this button might take weeks, months, or even years to develop, little by little, until it gets above the symptom threshold. So a few things I want to point out on here. There are changes occurring at the tissue before we even experience symptoms, okay? And that's good. And you're going to see, actually, we don't talk about it as much in this workshop, but there's a whole bunch of examples of how diagnostic tests, MRIs and X-rays, will show evidence of things that have no direct correlation to the pain. And unfortunately, finding tissue damage is the most likely reason that someone will say you need surgery to help this thing. But we know that those tissue changes are not directly associated with pain. And therefore, getting rid of those tissue damage issues through surgery oftentimes doesn't give you any long-term benefit from the pain as well, okay? This is harder to deal with, these cumulative issues, because it's not one thing. It's many, many things, many little things. And to give you a little bit of an analogy, I like to look at this bucket analogy. See the bucket down here? When you're below the symptom threshold, you got a little bucket, a little water in your bucket, okay? When you're above the symptom threshold, when there's more stuff that's occurred, you got water overflowing the top of that bucket, okay? So cumulative trauma, even though it's difficult to deal with because it's developing over time due to a lot of different things, though it's difficult, it's very predictable. When the tissues start to change, there's a predictable sequence of sensations that a person will feel. How many can say now, today, I can't be on my feet as long as I used to be. I get fatigued more quickly than I used to be on my feet. If you're middle age or older, that is a reality. That's a sign that tissue changes are occurring. And I got news for you. We are not meant to last forever. Time and gravity eventually win. And so fatigue, if it is left unchecked, if we don't do anything to change the environment, will lead to a little more water in the bucket. And then we're starting to experience discomfort. Discomfort are things like stiffness and a little soreness. It's not bad, but it's not comfortable. Get it? Most people will ignore that, and then they get more water in their bucket. Now we're experiencing pain. Pain is different than discomfort. It's more substantial. It's more severe. It's usually more, it's longer lasting as well. And again, if we get overflows to occur, now we're dealing with true tissue damage, true tissue injuries, things that are going to take more time and more money to deal with, okay? So I don't like calling people names, but we all are kind of like buckets. And tonight, really what we're going to talk about is what we can do to get some water out of the bucket. Maybe there are things we can do to grow the bucket so you can catch more water, or maybe there's some things we can do to slow down the significance of the dripping as time goes by. If we can do any one of those three things, or a combination of those three things, you're going to be successful. But if you don't change the environment, if you don't get to the root of the problem, what we almost always see happen is that over time, your issue becomes more frequent, more intense, and of longer duration. Most people will say at the start, yeah, it hurt a little bit, but it would go away. And we didn't do anything about it. And so as time goes by, it becomes a little more painful and lasts longer, and it's a little more often that you experience it. So this increase in frequency, intensity, and duration, that's the hallmark of cumulative issues that aren't being treated at the true source, where the root cause is not being found and dealt with. And unfortunately, as this FID increases, your mood worsens, and that affects the people closest to you. Your overall activity level declines. We're going to learn tonight that most musculoskeletal issues are due to movement problems. So when we move less efficiently or less comfortably, we don't move as often. And when we don't move as often, we're at risk for more significant health issues. We'll talk about those things. And it also makes it more likely you'll have one of those high-risk procedures that we talked about. But I'm going to encourage you tonight to consider a different, more structured process. And I think after hearing what I'm talking about tonight, you'll understand and say, you know what, that makes complete sense. So if you want a better mood, if you want to sleep better, if you want stronger relationships, if you want to reduce your chances for heart disease, diabetes, obesity, and depression, or if you already have any of those issues and you want to make it better, you got to get to the root of the problem so you can move better. Movement is the medicine, and it helps everything in life. Unfortunately, if you're like most people, the first thing that we do when we have a problem, as I've already alluded to earlier, is that we tend to ignore it. You know what? I'm not, it's not that bad. It's going to go away. Sometimes ignoring it means we make excuses for it. You know what? My mom had the same kind of foot problem. It's probably genetic. I can't do anything about it, right? Or I'm not as young as I used to be. I'm not a spring chicken. I'm just going to have to learn to deal with that. I can guarantee you this is one of the biggest sadnesses that I see in my life as a physical therapist. So many people have accepted the status quo instead of finding and fixing the problem. So don't ignore it anymore. Ignoring it only leads to a worsening as time goes by. I don't want you to be like so many of the people that we see in our clinic. Okay? We have too many 60-year-olds that behave like 80-year-olds. You heard what I'm saying? Premature aging as the result of problems that have not been solved. All right, so if you're like most, you ignore it for a while because the frequency, intensity, and duration gets worse. Eventually you get on the computer and you search for solutions. Maybe that's how you came across me. Most of the solutions that we get are simply ways to alter the problem. It might be a balm you put on there, some kind of a wrap, a special foot support. If you think about what most medical professionals provide as well, medications, injections, surgeries, physical therapists will do ultrasounds or electrical stimulation. That can maybe make you feel better for a while. And by the way, there's no problem with feeling better for a while. But those things simply alter the pain. It does not get to the root of the problem. So stop ignoring it and stop altering it. I want to teach you tonight the process by which we can actually solve the root problem. So here's a key point, all right? Number one, you cannot solve a mechanical problem with a medical intervention. It doesn't work that way. So, and related to that, number two, you cannot successfully manage a biomechanical problem or a movement problem with a biochemistry treatment. Okay, so you get up in the morning, you take a step and it's like, oh man, that darn heel hurts again and you're limping to get to your bathroom. Maybe you're limping fast because you really got to get to the bathroom. It isn't your foot saying, you know what, I'm low on ibuprofen. We don't have an ibuprofen count. We don't have an ibuprofen meter. The ibuprofen is not a natural substance. Okay, so you cannot treat a mechanical movement-based issue with a chemistry agent. It doesn't work. Movement-based problems need movement-based solutions from movement-based experts. Anything else is very likely to be, at best, temporary pain relief. All right, so on the topic of anti-inflammatories, so ibuprofen, especially when we take it at a little higher dosages, it has anti-inflammatory benefits. It's called an NSAID, a non-steroidal anti-inflammatory. Okay, or you can get prescription NSAIDs like naproxen, naproxen, lots of other kind of anti-inflammatories, and those can make you feel better because inflammation is what contributes to this experience of pain to some degree. But I want to point out to you that the normal healing process, whether it's a cut on your skin or a tissue damage internally to a ligament, tendon, or connective tissue of some sort in the foot. The second phase of healing is inflammatory phase. It's about day 3 to the end of week 3. And that is necessary, that 3-week time period or so. There's a new framework for blood vessel growth that's being developed during that phase. And that leads to these phases where the tissue gets endowed with blood vessels that feed nutrition and oxygen to that tissue to keep that tissue healthy over time. I'm seeing people raising their hand, and great. If that's an amen, keep giving me those hand raises. If you have something to say, if you have a question, though, hit that chat button. You can type it on there too. So keep that up. But my point is this: when we give people anti-inflammatories, when you take an over-the-counter anti-inflammatory, sometimes you're stunting something that needs to happen so that the body can get through that process to those activities that actually make a difference and give the nutrients that tissue needs to be healthy over the long haul. So the inflammatory phase is a natural, necessary, normal, important phase of healing. One of my favorite authors, who has been gone for a long time, is C.S. Lewis. Maybe some of you have heard or read some of this stuff. It was in the time of World War II that he wrote an essay called Miracles. And I've got a small quote on this. And I'm giving you this quote for a reason. Let's read it first. The magic is not in the medicine, but in the patient's body. What the treatment does is stimulate nature's functions or to remove hindrances. So why am I telling you this? First of all, I'm not a magician. Your medical doctor doesn't have access to special magic. Your chiropractor doesn't have healing hands. Nobody that can do you any long-term good is the magical side of this. The magic is in your body. We're designed, we are created with the ability to get well. And when we don't get well naturally, it's because something is in the way. And so if anyone's going to help you long-term, it's removing the body's natural the hindrances to the body's natural capabilities. So we're going to learn a lot more about that. But I want to tell you this, that's why there's no quick fix. The body will take care of itself if you provide the right environment for healing. All right, so let me tell you a little bit of a story. This is Heather. When I saw her, Heather was about 30 years old. She and her husband had gone on a trip of a lifetime to Hawaii, and they were walking in the mountains on lava, dried, hot, uneven lava. When she stepped on that lava, it created funky stress on her feet, and she started to get some heel pain. And that heel pain over the course of the next weeks and months got worse and worse. Heather's a school teacher. Heather's on her feet a lot, working with little kids. When she gets done with school, or maybe she did this in the morning. I think she did CrossFit in the morning. Sometimes she would run in the afternoon and the evening. She was always walking with her family, busy with her kids. All those things became painful, and she did less and less, all because of this stress that she experienced on this walk that continued to create problems for her. She tried medication. She got an injection in the heel. She, of course, did relative rest. Unfortunately, it wasn't helping. She had seen, I think, another physical therapist, a foot specialist. After she saw her family doctor, she'd seen a chiropractor. Nothing was helping. She came to see us because she had heard maybe you can do something different with this. And so she was kind of at the end of her rope, so to speak. For her, and we're going to talk more about this later, but this started when she originally stressed her foot on that lava as an inflammatory problem. She had an itis issue. But this had morphed over time into something that was no longer inflammatory, though it felt like it. She now had a tissue pathology issue. And it's because she didn't get past the inflammatory stage, and that whole maturation, granulation process didn't complete itself. And so it took less and less stress to re-irritate her foot as time went by. And guess what? Frequency, intensity, and duration were getting worse in her life. And so we found by doing a simple basic assessment that she had some issues in her hip, really easy to fix issues, by the way. So we worked on those things. We also did something called A-stem. We'll talk a little bit about that later. When you have a tissue pathology issue at connective tissues, and your plantar fascia is a common area with this, there is some benefit in a specific treatment that I'll talk about today as well. And after several weeks, she said that her pain had gotten to the point where it was extremely minor, and she could return to her CrossFit, her normal exercise activities. She went to wearing better shoes, more comfortable shoes, but she could stand all day long at school with very, very little problem after about 5 weeks of physical therapy care. So why do we teach this stuff? Number one, like I said earlier, it hurts when I move is the second most common reason people see the doctor. And though I highly respect doctors, I have many doctor friends, and the amount of medical knowledge they have is substantial. Unfortunately, the depth of their musculoskeletal knowledge is really, really poor. They have knowledge in other areas. In fact, I think most of the doctors out there that commonly see musculoskeletal issues only got book training in the first 2 years of their medical education. Never got any practical training on this stuff. And so unfortunately, then they default to the other things they've been taught, which is medications and injections. And if you're interested in watching something that's really powerful, I think it's 4 minutes or so, look up Keep the Wolves and Opioids Away. It was done by a physical therapy group in Colorado, I believe, about 4 years ago. This is when the opioid epidemic started to gain a little bit more traction. There's a lot of people that are being prescribed opioids for chronic pain. There are a lot of people taking opioids that they're getting from other people who've been prescribed because they're experiencing pain in their life, a variety of pain issues. And unfortunately, it's killing people. And so we know with opioids, it does not solve the problem, it masks the problem. And it kills people. In fact, in that video, two amazing statistics stuck out to me. America has 5% of the world's population, but it consumes 80% of the world's opioids. Amazing. And then the second thing, in combination with that, that is extremely scary. For those that get prescriptions for opioids, 1 out of 4, 25%, develop an addiction. It is highly addictive. It doesn't help. It is killing people, and it needs to stop. Last year alone, 70,000 people died from accidental opioid overdose. This year, we're making progress until COVID-19 hit. And because people couldn't see their doctors or their physical therapists or whatever as often, and by the way, early on, doctors could prescribe opioids via telehealth. We're starting to hear stories over the last month of people, the increasing experiences of overdose deaths related to opioid use. Surgeries are increasing significantly, over double increase over the last decade in surgeries. Unfortunately, surgeries are not usually a great option or not a long-term option, particularly if you don't get to the root of the problem. We'll talk about that later. All right, so like Albert Einstein said, let's don't be insane. Let's try something different because the same old is not working for people. So here's what we're going to talk about tonight. We're going to talk about the 3 most common types of foot pain. That's going to lead into an important discussion on the causes of foot pain. I want you to understand that tonight. And then I want you to also understand what long-term successful treatment of foot pain looks like as well, so you can stop wasting time and money and get back to what you want to do again. Let's first talk about the design of the foot. The foot itself is just like every other part of the body. It's a 3-dimensional mover. So the foot will move in the sagittal plane, that's the dorsi and plantar flexion, toe up, toe down motions. Okay, we got movement in this plane, pronation and supination, and then we got a rotational plane that happens at the foot itself as well. What happens when we take a step? So the foot is interesting when we just look at it, but it's most interesting when we put our foot on the ground. When we strike the heel, and then the heel goes to a foot flat position, the foot starts to pronate. The arch drops, the bones release, the bones become supple, and that allows the arch to drop towards the ground so the foot takes up more space, ideally, unless it's in a shoe that's not allowing that to occur. But if the foot can take up more space, you have better stability and contact with the ground, and then as you come over the foot and the heel starts to lift, that pulls tight on the arch, on the plantar fascia. That foot supinates again, where the arch raises, those bones lock, and it becomes a rigid lever by which we can propel ourselves forward with the push off through the toes. That is normal function. In fact, let's watch this. Oh, shoot. I forgot this one we can't watch. The YouTube user just took it off. This will give you some indication here of what happens. You have to look a little bit close. What you can see right here is the arch of the foot. Okay, all the muscles, all the ligaments, all the tendons have been removed. We just see this concave arch of the foot. This foot has not yet struck the ground. When I hit go, you're going to see the heel land. You'll see something happen with your heel. It's called the calcaneus. It moves a certain way. Those bones, although it's hard to see, those bones will unlock and that arch drops. And that's what helps the foot fall to the ground. And then as soon as that heel lifts, you'll see that arch raise. And it's ready for this rigid lever of propulsion. So take a quick look at this. It's 45 seconds. Here the heel is going to land. Then that foot drops. Those bones release a little bit. If that plantar fascia was there, you'd see tension on it, a stretch on that thing. Now the heel lifts and that arch raises and that fascia is getting pulled tight. That's the rigid lever. Slightly different angle. That calcaneus turns. Foot arch drops. The heel raises if the arch springs up again, and we got the rigid lever. Now that front view. Watch that calcaneus move inward, the arch drops with it. So that is normal foot function. That's pretty cool. Yeah, sorry, we can't watch that other one. That's a pretty neat one as well. All right, got to it. So that's what normal feet do. That's what normal feet look like. Unfortunately, the environment that we put our foot in is not normal. And you can see this. This is showing high heels, barefoot. I mean, this one, even in barefoot, you see a little contouring on that. The true foot position, you'd have a relatively straight line through all the bones of your great toe, which widens it out just a little bit more. So already this foot's probably been impacted by the environment it's been its entire life. But you can definitely see this narrower environment because these are high heels. There's a downward force towards the toes. We're going to talk about bunions here in a little bit. The environment of the narrow toe box can definitely contribute to bunion formation, but a lot of other things up the kinetic chain contribute to that as well. But I want to encourage you, you definitely need to look at the environment when you consider what to do for your foot pain. All right, let's talk about 3 types of foot pain. We're going to talk about bunions, plantar fasciitis, and Achilles tendonitis. I want you to understand that when I talk about the type of foot pain that you have, it is simply a diagnosis. It's a descriptor. And there is not necessarily a plantar fasciitis exercise program. There's usually not an Achilles tendonitis exercise program. There's not a bunion exercise program. And I say that because you don't treat what happens. You treat the cause of what happens. And so the treatment is trying to overcome the things that exist that created the stress that brought about the change and the pain at the foot itself. So let's start with the types. This is the bunion. Obviously, what we're seeing is this angular position of the lower 2 bones of the toe coming from the foot. And it usually gets painful on the inside. It will bump out a little bit like that. It's a lot of stiffness in that toe as well. You can see this lady's in high heels as she's taken off rubbing it. I hear a lot of people say, well, my mom had it too. Well, guess what? Your mom was in the same type of shoe probably as what you have been in as well. Certainly it can happen for anyone. It's much more common, at least earlier in life for women than it is for men. You can see that if you've been in this position, all this stuff's going to stretch, all that stuff's going to be in a shortened position, and we become the positions we put ourselves in. So it will get stiff in that position. So this is impacted by the environment of the shoe that we put our foot in. It's also impacted by what's happening up the kinetic chain. And I think as we talk about some of these other issues, you'll begin to appreciate what happens when the foot hits the ground if areas up the kinetic chain at the knee, hip, and above aren't doing their job particularly well. All right, plantar fasciitis. And I will tell you, I hate the term plantar fasciitis. In a little bit, we'll talk about the difference between itis and osis. Most of the things that we call fasciitis are really not fasciitis, they're fasciosis, or it's a fasciopathy issue. But when it first comes on, you probably do have inflammation. You can see on this picture, the inflammation is where your fascia connects to the bottom of the heel. It's kind of not in the middle of the heel, but slightly inside the middle of the heel. And though you can't see it very well in this particular picture, this fascia goes through the arch of the foot, and they have fascial bands that connect to each toe. So it kind of fans out as it gets to the foot. It is this fascia that gets tight when we go up on our toe, raise the heel to propel ourselves. It's part of the system that creates the rigid foot called the windlass effect. Okay? So early on, you might have some irritation and inflammation on that thing, but if that inflammation never resolves and you don't get to the later stages of healing, you're left with a tissue that is pathological, and therefore it doesn't take as much stress to make it irritated once more. And if you continue to treat that with an anti-inflammatory, whether that's a ingestible medication or an injectable medication, you're not solving the problem. And sometimes you need to do something to improve the health of that particular tissue, in addition to taking care of the origin of the problem higher up the kinetic chain. So this kind of problem, as I said early in our presentation, is not so bad when we're not on our feet, although there might be a dull ache. But the problem is usually first in the morning or when we first get up after a longer period of non-weight-bearing rest. Like if we've been sitting for a while at work and we get up and we put pressure on that particular area. So my question is it an itis or an osis? And my experience has said that people get stuck in this inflammatory phase. They try anti-inflammatories. They don't get the proliferation and remodeling to take place. So that tissue does not have a good, robust nutrition supply. The blood vessel growth has not occurred. And so that tissue is just easily failed. A lot more microfailure as time goes by. And so my encouragement is help that process to get through all 4 phases and make sure you take the stress off by looking at what's happening up that kinetic chain. Achilles tendonitis is just like plantar fasciitis, just affecting a tendon instead of a fascial tissue. But it also gets microfailures. The Achilles is the thickest tendon in the human body, so you'd think it would also be the strongest. Well, there are lots of forces acting upon the Achilles tendon. The Achilles tendon is much like any other tendon or any other white tissue in the human body, in that it does not get as much natural blood supply under normal circumstances. And then when we add an anti-inflammatory treatment, we're robbing of that even more. And so, of course, this is going to be more problematic. Both of these issues, when we sleep at night, the foot drops, which puts the arch in a shortened position, and then the healing tries to take place overnight when it's in a shortened position. Okay? When the foot drops, that foot drops down, this is Achilles tendon is also in a shortened position, and the healing takes place during those nighttime hours. So when we stand up and we put a physical stress over that part, we lengthen that tissue with weight-bearing forces, we just re-irritate it. That tissue is going to get microfailures occurring every morning. And so while it might be okay, at least for the arch, to put something under your foot first thing in the morning to support that arch, long term, if you use external support, it's going to have an impact on everything up the kinetic chain as well. So it's not a very good long-term option for people. All right, another way to stimulate feedback. So let's hope you're better at the polls than you were at your chat feature a little bit ago. I got a question for you. I'm going to launch this. You've heard about bunions, you've heard about plantar fasciitis, you've heard about Achilles tendonitis. For those of you that are on, it looks like we got 24 of you on right now. Tell me which one you think that you have. Okay, and if you don't know, put you don't know. If you know you have something, but it's not one of these things, tell me what that is. So yes, as suspected, a bunch of people saying plantar fasciitis. 87% with plantar fascia issues. We got 1 bunion, so that's really interesting. Achilles tendonitis, we got 18% of you with that problem. So good job, you're very good at polls. I love it. 18 out of you responded, so I really appreciate that. 1 of you is admitting that you don't know. That's perfectly fine. It isn't always easy to tell, and it could be something different. All right, great. I'm going to end the polling. We've got another one in a little bit, so I'll return to this eventually. Okay. Oh, shoot. Now I see that somebody had a comment, and I can't see it again. All right, so what are the causes of foot pain? All right, so I keep talking about up the kinetic chain. What is the kinetic chain anyway? The kinetic chain is the links that create movement, distinct and unique movements, 3-dimensional movements, and that's impacted by what happens when we deal with gravity and the ground, okay? When we're dealing with gravity and the ground, your foot hits the ground, everything changes, and there's a chain reaction that goes up your kinetic links, kinetic chain. And so if you look at what's happening at the chain, you can oftentimes get an idea of what is a primary cause, or really what we call the culprit of your problem, okay? And actually, if you look at people, if you were from outer space and had never been on Earth, and you arrived on Earth and you looked at people, you look at them and say, something's weird about the middle of their body. See that bump back there? That workhorse of the hips. It's really, really important, especially for bipedal people, people that are on 2 feet. So the hips are a big one. In fact, in my experience, the hips are absolutely the biggest issue, especially when combined with footwear problems that are also common. But we also got to look above the hips at the middle to upper back, your thoracic spine. And we also got to look below at the ankle foot itself. All right, so what about the hips? Well, hips can have movement dysfunction. Sometimes we will see hips that are capable of moving poorly. Hips in particular are 3-dimensional as well. It's a ball and socket joint, so they flex and extend. But when we land on our foot and we take a stride forward, that movement of 1 foot ahead of the other causes your pelvis to rotate over the femur. That's hip joint rotation. It's internal rotation specifically. And I see many people that have poor internal rotation of their hips. For whatever reason, a muscle tightness, the capsule of the joint gets tight, whatever it is, mobility at the hip can be a major problem. And so what happens is it sends that stress elsewhere. So let me tell you what I mean by that. Let's say you're working on an assembly line, okay? Or let's say this, you work at Powell Corporation and you got to put windows in the back of a trailer. And you do that with 3 people. You got 3 people that are working together. These are not light windows. These are heavy windows. If you've never seen this before, this is like Tetris. You're using all the 3-dimensional space in there. You're trying to get everything you can because space is money. And so you got to find a way to get these windows in there. And let's say one of those guys says, yeah, I really don't want to work. The guy's a little lazy. He doesn't want to do his job. The other 2 got to get the job done. So day in and day out, this one guy's not doing his job. The other 2 have to pick up the slack. Who's going to hurt at the end of the week? Who's going to hurt at the end of the month? Who's going to hurt at the end of the year? You see what I'm saying? If I go to those 2 that have been working really hard and I say, oh, I know you've been working hard. Let's rub your shoulders, okay? I can make that feel better. Maybe you need an ultrasound on that thing. Maybe we can hook you up with some medication. I know you're hurting. They're going to look at me and say, fix the real problem. The real problem is this guy that's not doing his share of the work, okay? So the hip can be that way. The hip is supposed to do big things. You can see by the way it's designed. When the hip doesn't do its job, other things suffer. And so we might have quicker heel strike because we can't get over that foot. We land a little bit harder, which forces the foot into pronation, which puts more stress on the inside of the Achilles tendon or on the arch of the foot. Or maybe it's so stiff that everything doesn't unlock very well. And so we don't get as much shock absorption. That's a problem. So we're going to show you something, I think I've got the heel whip. You'll see that in a little bit. That's what happens in particular when your hip flexors get tight for whatever reason. So these are major muscles. It's called the iliopsoas. So the iliacus portion comes from your iliacus of the pelvis. The psoas comes from your spine. They come down the front of the hip and they connect down there on the femur. So every time you take a stride and one foot stays behind, this muscle's getting put in a lengthened position. So if that's tight, it's going to have an impact on how far you can stride. And if your hip gets locked, other things happen, and it's going to be a premature heel lift or a whip that occurs. So let's watch this heel whip. Watch really closely this guy's left heel. You can see on here, watch how the heel twists when he gets close to the push-off phase. So I think they go through it a few times. There's the whip inward. You'll see it more on this one. Pivot through the toe, the heel whips inward a little bit. Yeah. So it's called an abductory twist or a heel whip, where that foot points out. That changes the stress. It's not the normal mechanical design stress on the body. And so any kind of limitations in that area of the hip is going to have impact on what happens around it. And oftentimes your foot has to make compensations for that limitation. Okay. Strength limitations can also increase load on the plantar fascia. If the hip, in some cases, this is true, the hip actually becomes too mobile. The knee falls in, the arch drops more. That puts more stress on the arch, also creates an abduction force on the great toe, which can contribute to that bunion positioning that we talked about too. All right, let's look at the mid to upper back. You might think this is really crazy, but it's time to get up anyway. I want you to get on your feet if you can still see me. Okay, I'm gonna do it too. All right, so I'm on my feet. I want you to have equal weight on each foot. Now, I want you to keep the feet planted, but rotate to your right. Tell me what happens to your left foot when you rotate as far as you can to the left. Do you feel more force on the arch or less force on the arch? Okay, when you go to the right, that arch is going to drop. Most of you will feel a little bit more force on the arch. There is an occasion where you might feel less, but that's a pathological issue as well. Now, think of the left foot now when you're standing and rotate to the left. We generally move to the outside of the foot and that arch raises a little bit. So what happens if we can't rotate very well through the mid-back? We can't rotate very well through the mid-back. Everything compensates sooner. So when you rotate to the right, the foot drops in more. When you rotate to the left arch raises more. It changes the way stresses are applied to other areas of the kinetic chain. And so with hip issues, which are really common issues for other musculoskeletal issues, we'll oftentimes see lower back problems and then lower leg problems, either knee or the foot. With thoracic spine issues, we'll often see lower back issues or neck issues, because those are the closest neighbors. That's another issue that can even impact things farther down that kinetic chain. And limitation is easily the most common restriction in that area, the mid to upper back region. All right, let's look at the ankle and foot. Let's look at the guy on the left here. Obviously, something's going wrong there with his left side. And you can also see because we're two-footed people and we're dealing with gravity in the ground, it impacts everything in that kinetic chain. If we look closer at what's happening, that calcaneus, or the heel, falls out, the arch drops in on that left foot. You're going to put more force on the arch, you're going to put more force on that big toe. And that might not be a great problem once or twice, but day in, day out, step after step after step, that can add up like a out-of-aligned tire in the human body. The problem with this is we don't know which is the chicken and which is the egg, okay? So is the arch causing problems up the kinetic chain, or is the hip have issues that are causing problems down the kinetic chain? And that's why an assessment to figure out why this is occurring specific to you is necessary, because if it's the hip that's causing the problem, we got to treat the hip to make the pain go away at the foot. But it could very well be a foot-related issue too. Here's another picture. One of you on the workshop tonight will definitely recognize this. I stole this off your website. Thanks. But yeah, so you can see what happens. I'm afraid my picture is a little bit in the way here. I didn't realize that was going to occur. And I don't think, oh, here, I can't move that. All right, you see that? So instead of that natural splaying with more surface area, we're forcing it into a less surface area, putting pressure on that thing. So if the foot becomes too mobile, you get overload of the arch, and that'll actually overload your Achilles on one particular side, called the medial or inside of the Achilles tendon. But if the foot's too stiff, there'll be a reduced load, and that basically will mean that we can't propel as well over that foot as well. The tight calf is very similar to what happens when you have the tight hip flexor. It's the increased premature heel lift, which again creates increased tension stresses on the arch of the foot. So definitely consider finding shoes that have a wider toe box and less elevation at the heel for a more natural foot fit. Bottom line is this: if your hips, thoracic spine, or ankle don't move properly, other parts pick up the slack, including your foot. And tissues are designed in an amazing way, but when they're asked regularly to operate outside of their design limitations or their thresholds, that's when we have problems eventually. That's cumulative trauma to a T. All right, so let's go into another poll question here. Poll question number 2. It's actually 2 questions in one. On the first one, you can only answer one. The second one, you can answer as many as you want. If you've seen a medical provider for your foot pain, what type of assessment did you receive? Number 1 is I haven't received any assessment in the past. Number 2 is the medical provider looked pretty much exclusively at the foot itself. And number 3, the option is the medical provider did a more broad assessment, a more global assessment, looking beyond the foot, but at the stuff up the kinetic chain as well. All right, and then the second question, you can put as many as you want. Who have you seen? Have you seen someone at the family doctor office? Have you seen an orthopedic surgeon? Have you seen a podiatrist, a physical therapist, a chiropractor, a reflexologist? What else? You could mark any of those that apply. I'm guessing some of you have seen multiple people before. Interestingly enough, nobody on here yet has seen a PT. Oh, there's the first PT response. But we see this all the time. People, for whatever reason, just don't get to the physical therapist enough. And in all honesty, and we'll talk about this, not all physical therapy is created alike either. Sometimes physical therapists do a really good job of altering the problem. We'll talk what that looks like a little bit more as well. All right, so we had 2 of you that had a more broad assessment. Good for you. That's pretty rare. 41% said they did an isolated assessment, and 47%, the biggest number, haven't had any assessment at all. So there's certainly some opportunity for all of you, in particular those that haven't had any assessments yet. So that's good. Most of you have seen a podiatrist. Family doctor is the second most common, and then the chiropractor. Okay. Thanks again. We have one more poll coming up in just a little bit. All right. Gene, I see you have some questions. At the end, I'm going to give you an opportunity to answer those questions. That's great. We're going to talk about spurs. not directly, we're not going to talk about spurs, but spurs are the result of degenerative changes because of inefficient stresses. So everything that we talked about with regard to plantar fascia and those forces that cause that, or the Achilles tendonitis, all those things will do the same thing. They create stresses at areas where the body is not equipped to handle that kind of stress, operating outside of the threshold. It creates an inflammatory response. The body tries to heal that, and when it heals it, it lays down tissue, and sometimes spurs are the result of that. So spurs are simply another sign or symptom of stresses that have been inappropriately applied to a particular body part. So great, thanks for those questions. But at the end, if you have more, I definitely want to hear those things. Okay, so let's talk about what successful treatment looks like. I want to first talk about the most common treatments, but I want to point out that everything you see on this list right here, they're definitely the most common. Don't get to the root of the problem, they simply mask the problem. It is said that orthotics have about a 50% success rate, but I put success in parentheses because if your success is it makes it feel better, then that's okay. But all too often that pain relief does not last. And the problem with anything where you put something over the foot, whether it's a tight shoe, an orthotic to support it, or a boot around it, it has an impact on everything that happens up the kinetic chain. So that can definitely impact other issues up the kinetic chain as well. So I'm a strong proponent whenever possible of trying to make your body behave appropriately before you go to external supports for those kind of things as well. That means you got to have a root cause analysis. So last poll question. I'm going to get to question number 3. It's what type of treatments have you had in the past, if you've had any kind of treatment? So we've got 10 options here. You got education, you receive modalities, medications, or injections, all examples of altering the problem, all very common, by the way. There's something called ASTEM, which we'll talk about in a little bit, or other instrument-assisted soft tissue mobilizations. Manual therapy while you were passive, meaning you were sitting or laying down, or was there some manual therapy while you were active, dynamically moving with your foot on the ground? Table-based exercises or functional exercises. By functional, I mean if we exist between gravity and the ground and our foot's on the ground, functional exercises try to simulate what happens normally in daily life, foot on the ground exercises. One-on-one care, unfortunately, it is legal for therapists to see multiple people at the same time. I would never recommend it. You are not getting individualized care if the client is trying to work on more, or if the therapist is trying, or whatever medical provider is trying to see more people at one time. And then, yeah, you see, my provider worked with multiple people simultaneously, and my treatment stayed the same throughout the entire course of care. Anyone else want to give some thoughts on that? Mark all those that apply. It could definitely be many of those. I'm seeing lots of you have done functional exercise. That's really cool. We're going to talk about one particularly interesting exercise for those of you with plantar fascia issues. Yeah, so I actually think almost all of these are fine. But if you had all of these but did not have functional exercises and you did not have care that changed as your symptoms and progress occurred. If it stayed the same the whole time, it's not adapting to different needs that change as your body changes as well. And then I think ASTEM or another instrument-assisted soft tissue mobilization is an important consideration to make as well. Great, good. You guys are good at polls. Appreciate it. All right, so here's what I'm saying about successful treatment. My 24 years of experience, it has to be individualized. Now, go back to what I said earlier. There are no plantar fascia exercises, okay? There are no Achilles tendonitis exercises. What's the cause of your problem? And let's fix those things. It's individualized to your specific problem. And in order to find the problem, you got to look whole body. It's a holistic approach, not just a foot problem. You have foot pain because of other problems. Okay, you need to be educational and empowering. And empowering that, I mean, here's what you need to do. And then as time goes by, here's the new stuff you need to do. And eventually, here's the last thing you need to do. Okay, the other thing I'm going to point out are 2 things. Functional loading. Now, that can mean things like lunging, stair climbing, those kind of things, particularly if that treats the root problem. But there is some evidence that shows that eccentric training of the muscles that support the foot, in particular your calf muscles, are effective for plantar fascia problems. So oftentimes what I'll do is something like this. You'll be standing on the edge of the step with your heels off the step, and you raise both heels up. And if you have right heel pain, I'll have the person Lift their left foot up. Don't worry, you're using your hands. And then lower the heel back down, even below the step height if possible. That's a lengthening training at a specific version of eccentric training. Helps train the foot for loading that occurs when your foot hits the ground really well. And then we have another treatment called ASTEM, which is pushing through the tissue using tools. Why is that important? Remember the 4 phases of healing: the proliferation and maturation phases, those end phases that allow for this full supply of blood and all the nutrients carried by the blood to that tissue needs to occur. And instrument-assisted work has been shown to help facilitate the maturation process, enhancing blood flow to tissues that don't get good blood flow. So I think you need this holistic approach. You need probably some eccentric training and some ASTEM or something like that to have true benefit for these issues. What does that really look like? Well, instead of that sudden tissue damage and correction, instead of that progressive worsening of frequency, intensity, and duration, it's getting it below that symptom threshold by making adaptations to the real problem. All right, so you've reached nearly the end here. One other thing I want to talk about here tonight. Number one, I've given you a lot of information. I've literally fire hosed you with a lot of stuff. I know it can be overwhelming. And frankly, you're not going to be able to take in all this information. So our memories are limited, and that's a problem. The other thing is, you might know what type of pain you have, but you may not know, is it a hip issue? Is it a foot issue? Is it a mid-back issue? You don't know what your specific root problem is, and it's really difficult to do that with a workshop. Finally, knowledge really isn't power. It's only knowledge that you can implement or apply. And so I'm going to encourage you to really go one step farther to find the real solution for this thing. Find what tools you need to practice and repeat at home. So I'm going to, for those of you that have stuck around here, you've done such a good job. If you're interested in spending 20 minutes in person or online if you need to because of COVID-19, we can have one of our movement experts spend just a little bit of time with you, do some brief assessments, and give you a sheet that says, here's what type of pain you're having, here are the primary true problems that are causing that, and here's what a path to progress and successful treatment would look like. And ultimately, we want to give you hope, because that hope has been taken away if you've been dealing with problems. So the benefit is you get to the root of the problem, you know what you have to do to make it go away, and you're going to be able to stop spending money and time on things that don't help in the long run, and you can stop making excuses for your pain too. Find your old self again. All right, quick recap. If it hurts when you move, you're in the right place, but the thing that hurts and the thing that's the true problem are two different issues. So look beyond the foot to find the problem to the foot. There are only 3 ways to deal with the problem. You've tried ignoring it. You've probably tried altering it. Most people do. I want you to handle the problem, okay? You need to have an expert look at that and figure out what specifically you need. So I want to invite you to this free natural foot pain consultation. It's only 20 minutes. You're going to get a ton of value out of it. In fact, in nationwide assessments, it's about $150 worth of value, and you don't have to pay anything for it. And there's no obligation beyond that time with you either. We're so convinced it's going to be beneficial for you that we offer this guarantee at $150 of value. If you go through this assessment and say, you know what, didn't help me, then we'll give $150 to the charity of your choice. So I want you to get out your phones, okay? Open up your camera because I got something I want you to scan in a little bit. No matter what, if you come and do this free screen, 20 minutes, you'll have something. You'll be able to take that consultation summary. So you've got that information to take with you moving forward. So if you scan that QR code, if you put your camera on that, if you have a smartphone, it'll give you a link. You click on that link and it'll go to this spot on our website where you just put your first name, your last name, your email, so one of our friendly care coordinators can contact you. And then which of our 7 clinic locations you want to do it in, or if you're not located close to one of our clinics or you're not comfortable going out yet because of your situation with COVID-19, we have an online telehealth option too that works just fine, okay? Now, if you'd rather communicate with me directly about this, that's fine. I'm going to stay on the line here in a little bit. And if you want this and you're like, I don't have this technology, on the chat button, just say, yes, I want to have this screen. A couple weeks ago, we had a lot of slots available. We don't have many slots available now. As COVID-19, people get a little bit past that. We're seeing more and more people in the clinic. So I'd say contact us soon before these slots get filled. And like I said, in clinic or online. is an option with this. All right, so I'm going to stop sharing. That way I can see the questions. I'm actually going to stop recording as well. Did pretty good. We're right at an hour. All right, so again, if you want to have one of those, take the screen. I see you, Ruth. We'll make sure that you get one of those. I'll have them contact you if we don't hear from you. Let's see. Call in Jean tomorrow. We can do that. Yes, we got another person on the screen. I'll make sure you contact that. If on this screen, if this is the way you're going to do it, if I don't see your name, if you didn't put your name on there, I got to be able to cross-reference you with the people on our list. So just put your name on there too. Doesn't insurance pay for this? If it's determined that you would benefit from physical therapy, and you say, yeah, I'd like to do the physical therapy, then we have our care coordinators do a benefits check for you. And almost every case, it will be a benefit that is covered by insurance. What we do is we have our care coordinators check the insurance benefits so you know going into it what kind of your financial responsibility would be for that. And I would tell you for most conditions that are cumulative in nature in the lower extremity, it usually ends up being 7 or 8, sometimes up to 10 visits over about 5 weeks. That's average. Now, some people are a little quicker. It takes less time and less visits. Some people require a little bit more time. But that's generally about it. Heather, if you're interested, you can call tomorrow too, or I can have our care coordinator reach out to you. Somebody on Galaxy S9 says, yes, I don't know who you are. So if you can put your name on their Galaxy S9, that would be awesome. This is a complimentary check, Teresa. No fee at all, no cost, no obligation. You spend 20 minutes, the expert will tell you what they learn and kind of what we give you is what we call the path to progress or the path to success. And so at that point, if you decide you want to go further, then that's up to you. But it's not a high pressure. We want to give you valuable information. Marianne, we will call tomorrow, or you can call tomorrow too. Bonnie, yes, I got you now. Thank you for that. Isn't ASTEM the same as shockwave therapy? That's a really good question, Heather. It is not. Shockwave therapy or electrical stimulation is, yeah, you've got a machine with electrodes hooked to an electrical source, and depending upon how it's set up, different waveforms act upon that area. So that's kind of it's an electrical treatment. ASTEM is a physical treatment using tools. You push directly through the tissue. And that actually, it's called ASTEM because it stimulates the body to go through this maturation process. If you want to know the science behind it, the research shows that when you stimulate that tissue with the ASTEM tool, it will release macrophages and fibroblasts. Macrophages are like Pac-Man. They eat up the cruddy, crappy pathological tissue, and then it's followed up by these fibroblasts. And fibroblasts literally means development of fibers. So it lays down these new fibers. If you look at Achilles tendonitis or plantar fasciitis, if you looked at it under a microscope, the area that's injured, those tissues would be unorganized. It would look like cooked spaghetti in a bowl. What those tissues are supposed to look like are nice, long, striated tissues. It should look like uncooked spaghetti in the box. So that's a sign that these tissues have had inflammation and injury. They've tried to heal, but the body cannot complete the process. There's not enough blood flow or nutrition to that tissue. And that tissue doesn't handle tension stress well over time, and it breaks back down. More microfailure occurs. So that ASTEM treatment provides maturation or provides an actual change of the tissue so that tissue can handle stress more. But also you need to go back and say, okay, if my hip's the thing that's causing the problem, if you help that tissue to heal and then take the stress off because your hip's doing the job a ton better than it was before, you've changed the entire environment. And now that stress is not going to cause this tissue to fail with microfailure over time. All right, yes, I will have the people call me. It says HE, it's cutting off right now, but I think that's probably Heather or someone like that. We'll figure out who you are. Shockwave therapy breaks up tissue and sends red blood cells to tissues to heal it. There's a lot of theories as to what shockwave therapy does, but it's not really terribly well understood, actually. And in my experience, I don't know any research that shows that it creates any change in the actual tissue itself. It can change the sensory process and therefore reduce the pain to some degree for sure. And it can help the body release some, what it's called endogenous, your own endogenous opiates, so your own pain relievers, instead of having to take something orally as well. But in my experience, that's not been a good long-term solution relative to some of the other things that we've talked about. Yes, Newton will give, Ruth will give you an option of where you want to be seen. Anyone can pick whichever location they prefer for that. Any other questions for anyone here? Yeah, I'm excited that you've all been on good attention here throughout our talk. I'm excited that you guys are going to get some opportunities to find the root of the problem. Thank you, Teresa. I'm glad that you found it valuable information. When I was a young person, when I was in high school, you go through those tests to find out what you need to be in life. Your guidance counselor had you do those things. Guidance counselor did the test. He scored it and said, hey, you're supposed to be a teacher. And I said, I don't want to be a teacher. So I actually went through and I changed some of my responses. I don't know what it told me what to be, but I felt better about it. But the ironic thing is that darn test was right. What I like most about my job as a physical therapist is the fact that I can teach people, give them solutions. So awesome. I'm glad that you found that valuable. Where are all our locations? Good question. So we're in central and south central Iowa. So from northwest to southeast, we're in Ames, Des Moines, we're in Newton, Pella, Oskaloosa, and down in Centerville. And then last summer we opened one in Waukee too. So we're actually 7 different counties, all different counties. But Ames, Waukee, Des Moines, Newton, Pella, Oskaloosa, Centerville, or telehealth online. So that's good. Yes, I would like to address the other issues that contribute to that as well. And that time that you spend with the expert will definitely help you do that. Janice, yes, we will get you in soon. I want you to be able to walk again. There is one downtown Des Moines, right on 3rd Street, like a block and a half south of Wells Fargo Arena. Some people say, I don't want to go downtown. It's really simple. Just a couple blocks off of 235. And we have free parking just to the south of our building. So it's really easy to get to. So yes, if that works well for you, we'll make sure you get to that particular location. Any other questions from anyone? Happy to help if I have any other questions to answer. All right. Thanks again, folks. Really appreciate your interest. I'm sorry you're experiencing pain, but I'm hopeful that we can help you do something about that. So again, if you have any information you want to share with me, you can respond to any one of those emails we've sent to you in the past. It'll get to me so I can answer those questions too. Don't hesitate to reach out. We want to be a resource for you as much as we can. Deb, yes, we will add you to the call list. We'll make sure that we get you in. All right, wonderful. We'll see you all soon.